Endometriosis is defined as the presence of normal endometrial tissue abnormally implanted in locations other than the uterine cavity. Approximately 30 to 40% of women with endometriosis will be subfertile. It was once believed to be due to retrograde menstruation that travels back up towards the fallopian tubes, but that does not fully explain it showing up in far-off places unless the lymphatics are to blame for distant spread. Risk factors for endometriosis include the following: family history of endometriosis, early age of menarche, short menstrual cycles, less than 27 days, long duration of menstrual flow, greater than 7 days, heavy bleeding during menses, inverse relationship to parity, i.e. increased number of miscarriages or stillbirths, delayed childbearing, and defects in the uterus or fallopian tubes. About 1/3 of women with endometriosis remain asymptomatic. However, others may experience the following symptoms: dysmenorrhea, painful menses, heavy or irregular bleeding, pelvic pain, lower abdominal or back pain, dyspareunia, pain with sex, and also dyschezia, pain on defecation, often with cycles of diarrhea and constipation, bloating, nausea, and vomiting, groin, inguinal pain, pain with urination and or urinary frequency, pain during exercise. In the typical patient, the ectopic implants, that is, implants of endometrial tissue outside the uterus, are located in the pelvis, ovaries, fallopian tubes, vagina, cervix, or uterosacral ligaments, or in the rectovaginal septum. More unusual implantation sites: laparotomy scars, lung, diaphragm, kidney, spleen, gallbladder, nasal mucosa, spinal canal, stomach, breast, can be responsible for bizarre symptoms. Laparoscopy provides a definitive diagnosis of endometriosis. Laparoscopy is a procedure where a probe with a fiber optic camera and a light on one end is inserted through a very small incision, usually less than a half-inch long, through the abdominal wall. This allows for viewing of abdominal viscera. This is an alternative to larger incisions in open surgery, which leave the abdominal area at greater risk of infection or post-surgical healing complications. Usually, more than one small abdominal opening is created, either to gain a more complete view or to insert surgical instruments when a procedure needs to be performed. That's why you may find laparoscopically assisted surgeries referred to as keyhole surgery. After a patient interview, if endometriosis is suspected but laparoscopy is not performed, non-invasive tools such as palpation, ultrasound, or MRI may be useful if the endometriosis has caused extensive scar tissue or cyst formation. Some doctors believe that endometriosis should be suppressed prophylactically by continuous combined oral contraceptives, GnRH analogs, medroxyprogesterone, or danazol in order to cause regression of asymptomatic disease and enhance subsequent fertility. The goal is to stop the menses completely until the patient desires to get pregnant. NSAIDs are used for pain. A prophylactic treatment is a preventative treatment. It comes from Greek, pro meaning before, and phylaxis meaning to guard against. It was transferred from Greek to modern Latin, where it acquired its current spelling. Dysfunctional uterine bleeding, DUB, is the global term that includes anovulatory uterine bleeding, AUB. It is irregular uterine bleeding that occurs in the absence of pelvic pathology. It is the disruption in the normal cyclic pattern of ovulatory hormonal stimulation to the endometrial lining. The bleeding is unpredictable and may be excessively heavy or light, and may be prolonged, frequent, or random. It is a diagnosis of exclusion. A diagnosis is reached by ruling out other possibilities based on the information at hand. It can be due to polycystic ovarian syndrome, PCOS, since that is associated with anovulation, lack of ovulation. Medical conditions which can result in DUB include thyroid disorders, bleeding disorders, liver dysfunction, pituitary problems, pregnancy, or medications. Anytime a woman presents with DUB, a pregnancy must be ruled out since it may represent an ectopic pregnancy or inevitable miscarriage. With lack of ovulation, there are constant non-cycling estrogen levels that stimulate endometrial growth. Proliferation without periodic shedding causes the endometrium to outgrow its blood supply, which causes the tissue to break down and slough irregularly. Chronic stimulation by low levels of estrogen will result in infrequent light AUB. Chronic stimulation from higher levels of estrogen will lead to episodes of frequent heavy bleeding. Severe bleeding can lead to anemia. Most cases of DUB can be managed with hormones such as oral contraceptives, progestins, or a combination estrogen and progesterone. Other agents include non-steroidal anti-inflammatory drugs, NSAIDs, ergot derivatives, antifibrinolytics, gonadotropin-releasing hormone, GnRH, agonists, and desmopressin. In women who have completed childbearing, an endometrial ablation can be performed to permanently scar the lining of the uterus. Otherwise, a hysterectomy can be considered in extreme cases. In PCOS, multiple fluid-filled sacs develop on the ovaries. It is an endocrinologic disturbance that is defined as chronic anovulation, production of excess male hormones, hyperandrogenism, amenorrhea, and DUB, metabolic syndrome, or insulin resistance, obesity, and hypertension. A brief digression. Metabolic syndrome is a collection of symptoms including high triglycerides, low HDL, the good fat, high blood pressure, abdominal obesity, and insulin resistance. Having at least 4 of these simultaneously defines metabolic syndrome. Like obesity and hypertension, metabolic syndrome can occur independently of PCOS, but it is one of the symptoms of PCOS. In medicine, the term syndrome is applied to diseases that are defined as a collection of symptoms which, when occurring together, define a unique condition. Note we are talking about polycystic ovarian syndrome. We have also examined AIDS, acquired immunodeficiency syndrome, and so forth. And now, back to PCOS. Signs and symptoms of PCOS include menstrual dysfunction, anovulation, hyperandrogenism, and hirsutism, hair growth in unwanted places, acne, infertility, obesity and metabolic syndrome, diabetes, obstructive sleep apnea. Treatment. In adolescents with PCOS and hyperandrogenism, hormonal contraceptives and metformin are treatment options. For menstrual abnormalities and hirsutism, acne, hormonal contraceptives are the first-line treatment. For infertility, clomiphene and letrozole are the first-line treatment. For metabolic and glycemic abnormalities and for improving menstrual irregularities, metformin is beneficial. Weight loss and exercise. One of the most common gynecologic complaints among women during their reproductive years is pain during sex, or dyspareunia. Pain during sex can begin with initial penetration, with thrusting, or a combination of the two. Pain during sex can be a result of anatomic variation, such as size, shape, the orientation of reproductive organs, nerves, and muscle development. Hormonal changes, underlying infections or diseases, and emotional factors can all impact a woman's ability to enjoy sexual intercourse. Likewise, a partner's anatomy and technique can affect whether a woman can experience the pleasure of sexual intercourse. One of the easiest ways to classify the different reasons for painful sexual intercourse is to divide the pain into initial penetration pain and deeper penetration pain. For instance, women who have pelvic organ prolapse, such as a dropped bladder or uterus, which is uncommon unless the woman has had multiple pregnancies, can experience both initial and internal pain during sex. Diseases or conditions that can cause pain during sex. There are diseases of the female reproductive tract that can cause pain, such as pelvic inflammatory disease, PID, an STD that scars fallopian tubes, ovarian cysts, benign growths on the ovaries, endometriosis, where the lining of the uterus spreads to other areas, adenomyosis, which is when the lining of the uterus buries into the muscle of the uterus, and skin rashes of the vulva, such as lichen sclerosis and others. Bladder diseases such as interstitial cystitis, autoimmune diseases such as Sjogren's syndrome, gastrointestinal conditions such as inflammatory bowel conditions, childbirth lacerations, diabetes due to frequent yeast vaginitis. For dyspareunia, in these cases, treat the underlying cause, such as medication for vaginitis, estrogen for vaginal dryness, birth control pills for endometriosis, antibiotics for STDs such as PID, and surgery for cysts. Dysmenorrhea is painful menses. This can be due to prostaglandin release during normal menstruation. If it starts with the onset of puberty, this is called primary dysmenorrhea. Secondary dysmenorrhea starts later in life and may be due to underlying pathology. Clinical features of primary dysmenorrhea include the following: onset shortly after menarche in about 6 months, usual duration of 48 to 78 hours, often starting several hours before or just after the menstrual flow, cramping or labor-like pain, background of constant lower abdominal pain radiating to the back or thigh, often unremarkable pelvic examination findings, including rectal. Clinical features of secondary dysmenorrhea. Dysmenorrhea beginning in the 20s or 30s after previous relatively painless cycles. Heavy menstrual flow or irregular bleeding. Dysmenorrhea occurring during the first or second cycles after menarche. Pelvic abnormality with physical examination. Poor response to non-steroidal anti-inflammatory drugs, NSAIDs, or oral contraceptives, OCs. Infertility, dyspareunia, vaginal discharge. Two conditions which cause secondary dysmenorrhea are endometriosis and its sister disease, adenomyosis. Adenomyosis is a sister disease in that portions of the uterine lining are found in places they should not be. In the case of endometriosis, the implants are outside of the uterus. In adenomyosis, the uterine lining forms little pockets inside the muscular wall of the uterus. An inflammatory response occurs, and during the menstrual cycle, when estrogen levels surge, these pockets expand and cause a variety of symptoms. Abnormal bleeding, chronic pain throughout the cycle that acutely worsens during menstruation, and heavy, irregular bleeding are common symptoms. Fibroids are benign muscle tumors of the uterus. The symptoms are heavy bleeding, often gushing, cramping, pelvic pressure, pain, frequent urination, miscarriages, anemia, painful menstruation, painful sex. Diagnosis can be made by pelvic ultrasound and ruling out infections and other pathology first. Treatment is primarily medical in the form of hormonal contraceptives and NSAIDs, diclofenac, ibuprofen, ketoprofen, meclofenamate, mefenamic acid, naproxen. Vaginitis, inflammation of the vagina, is the most common gynecologic condition encountered in the office. It is a diagnosis based on the presence of symptoms of abnormal discharge, odor, vulvovaginal discomfort, itching, burning, or a combination of these. Cervicitis may also cause a discharge and sometimes occurs with vaginitis. Normal discharge is usually clear or milky with no malodor. A change in the amount, color, or smell of vaginal discharge, irritation, or itching or burning could be due to an imbalance of healthy bacteria in the vagina, leading to vaginitis. The most common causes of vaginitis in symptomatic women are bacterial vaginosis, 40 to 45%, vaginal candidiasis, 20 to 25%, and trichomoniasis, 15 to 20%. Yeast vaginitis is caused by a fungus known as Candida. It presents with itching, pain, burning, whitish discharge, and dyspareunia. It is triggered by environmental changes such as heat and pH. Excess glucose seen in diabetes is another contributor. Oral and topical antifungal drugs are the treatment, but their effectiveness is waning. Bacterial vaginosis is caused by an imbalance of good and bad bacteria and elevated pH. Bacterial vaginosis, BV, comes with a watery discharge, some external irritation, and of course the distinct smell, an ammonia or amine, fishy odor. Another theory is that BV is caused by the sexual transmission of a specific pathogen, e.g. Gardnerella vaginalis, or unknown bacteria. The link between BV and that of STIs supports the hypothesis that BV is sexually transmitted. One common denominator is the presence of sperm. Douching is a risk factor also. It can be treated with antibiotics. Trichomonas is a parasite that is sexually transmitted and leads to a frothy yellowish green discharge, irritation, and itching. It is treated with antibiotics such as metronidazole. An ovarian cyst is a sac filled with liquid or semi-liquid material that arises in an ovary. Most are benign and many are asymptomatic. Small cysts or follicles form around an egg each month, which is then released with ovulation. Follicular cysts may result from a lack of physiologic release of the ovum due to excessive FSH stimulation or lack of the normal LH surge at mid-cycle just before ovulation. Hormonal stimulation causes these cysts to continue to grow. They may manifest as a discomfort and heaviness. Corpus luteal cysts that persist after ovulation and reach 3 centimeters are considered abnormal, but often resolve without incident. Solid and fluid mixed cysts can be malignant or benign. and warrant follow-up until they resolve. So far, Dr. Cull has provided us with insight into the female reproductive system and into diseases of this system. Next, we will look into normal pregnancy and pregnancy problems.